Fantastic. Thank you, everybody, for joining us tonight. I am absolutely chuffed to be able to do this veterinary webinar because I'm sure that, well, I know that everybody will find it really useful. We've got loads of people signed up tonight. I'm sure there's loads and loads of questions that everybody's desperate to ask. If you put your questions below in the chat in the Q&A, then we will answer them at the end. I know that a few people also emailed in a few questions too. They have been passed on to Lou and Abby. And again, they will be addressed at the end. So without further ado, I will hand over to Lou. Oh, that rhymes.
Uh, Good evening, everybody. Thank you so much for joining again. I think I've made a bit of an oops because I forgot to forward the Agria slide to Abby, and I don't know whether you had that in or not. But before we start, a massive thanks to Agria for supporting these webinars yet again. I would definitely, we will send out the QR code to everybody with the recording. But I think this is like a very poignant topic to, if you want to look into your insurance of your former racehorse or querying your policy, go and check out Agria. They are brilliant. They're so supportive of the ROR. And their owner actually has former racehorses as well. So she completely understands everything that we're all going through. So go and check them out. And it's not just for your horses, but for your dogs and your rabbits. Please do go and have a look. This evening is, I'm going to say, a bit of a mixed presentation, but it's mainly going to be Abby talking with me interjecting every now and again and having a bit of a conversation. For anyone that's been on the previous webinars, normally we start off with how the thoroughbreds are put together. I will spare you that this evening, because we're going to go straight into thoroughbreds, common problems like kind of seen with ex-racehorses. And I'm going to hand over to Abby. And Abs, I don't know whether you want to take over, introduce yourself, and off we go. Have you put partner on that yet? No, you haven't.
No,
Um,
not yet. That's two to go. Yeah, so I'm Abby. I've been a vet for too long, nearly 12 years, 10 of which have been at Towcester. I also own my very own ex-racehorse. That's Annie on the front slide there. So Lou had the pleasure of meeting me as a client. I had the pleasure of meeting her as a client on Boxing Day with emergencies, and she ended up feeding me dinner. And then I've pestered her as an instructor and trying to get my horse to canter right in control ever since. So yeah, kind of been through my fair share of these problems as an owner, and also see them plenty day to day as a vet as well. Hopefully, someone's going to kind of be on the questions and things. So if you do have any questions as we go along, feel free to kind of, yeah, pipe up and I can try and answer any questions you might have. So let's go. So we're kind of covering in this like the big, I say the big three. There's lots of things that all horses suffer from, but especially ex-race horses. But kind of covering three main areas that we see a lot of. First of which is gastric ulcers, which I'm sure many of you have experienced, probably even more of you have heard about, read about. It is a really, really common problem, and ex-racehorses aren't, well, racehorses and ex-racehorses aren't the only ones that suffer them, but certainly we see a correlation with ulceration and intensity of work. So obviously racehorses, when they're in high intensity work in training, 90% of them have gastric ulcers. That's to say, not to say sports horses, performance horses don't. It's also really prevalent in kind of endurance things. Again, they're doing really high intensity work there. There's a huge wide range of clinical signs. I think the ones that we always think about are kind of the fussy eaters, girthy, kind of poor coats, possibly like colicky. Sometimes it's not necessarily the skinny horses. It can be the fat ones too. It can be tail swishing, teeth grinding, reluctant to go forwards, kind of reaction when you put your leg on. Lots of different things can lead us to thinking, okay, we might be dealing with some gastric ulcers here. And there are two types of gastric ulcers. So we kind of have a bit of a catch-all phrase of, oh, my horse has got gastric ulcers. But actually, we split it up into two different types of disease. So we've got equine squamous gastric disease, which affects the squamous part of the stomach, which is the top half of the stomach. And they are the ulcers that are typically associated with kind of low fiber, high starch diets, not enough turnout, not enough forage, what we would consider kind of management. And I think we are seeing less and less of those as we're all more aware of what kind of the best management for these horses is. The second type is equine glandular gastric disease. So that affects the glandular part of the stomach, which is the bottom half of the stomach. That part of the stomach is actually always covered in acid, whether your horse is managed well with lots of forage or not. And we know slightly less about that. So it sometimes is more associated with stress, pain, things that affect kind of the blood flow that we think to that mucosa. So I think probably intensity of work, actually when these horses are working really hard and all of their blood flow is going to muscles and hearts and lungs rather than stomachs, that could have an impact. So both we will diagnose on gastroscope. This is the only way to know if your horses have ulcers or not. We're always really aware as vets that I think actually gastroscopy is probably one of the biggest hurdles and the actual procedure for people getting diagnosis, because unfortunately it's not as quick as a blood test or listening to their heart or looking in their eyes. They have to be starved for 16 hours, so their stomach is nice and empty. And we sedate them and then pass a 3-meter camera up their nose, down their esophagus, and into their stomach, which allows us to visualize what ulcers, if any, are there. We do find it actually really, even though we think, oh yeah, that horse definitely has ulcers, I'm sure they've got ulcers there. It can be really, really useful because one, we can know if we're barking up the right tree or not. And if they have got ulcers, what type of ulcers are they in this kind of top half here, which would be those squamous ulcers, or in the bottom half, which would be the glandular ulcers. And they are treated slightly differently, again, have different risk factors, so we might change their management in different ways. And again, how nasty are those ulcers as well? So it's really useful for us to scope them if that's a possibility. I thought I'd show you lots of nice gruesome pictures for you. So these are this is squamous glandular disease. We grade these on a scale of 1 to 4, with 1 being mild, what we call hyperkeratosis, and 4 being kind of the worst. So you've got a normal stomach on the left. We should have that really nice delineation between the squamous mucosa at the top and the glandular mucosa at the bottom. You can see in most of these pictures, we've got fluid in the stomach, and that's actually this acid and juices that the stomach produces. These horses will all have had water taken away about 2 hours prior to us scoping them. So that's kind of what's produced continually by the stomach. And then I don't know if you can see my mouse pointer or not, but that one kind of going along at the bottom, you can see the big areas of bleeding there. This is grade 4 ulceration. This was an ex-racehorse that was skinny, was fussy, was being given ad lib hay, but actually not eating it, probably because his tummy hurt too much. And you can also see with him what we call that hyperkeratosis, so the yellowy, thickened area that looks a bit like scar tissue, which is probably where he's had a lot of ulceration before. Kind of that top one just in from the left, you can see our camera going into the stomach at the very top there, and what's called the lesser curvature. We've got some grade 2 to 3 ulceration on that there. And again, towards the right-hand side, we'd probably say that's grade 3. It's pretty extensive. but we haven't actually got any active bleeding as such. But pretty extensive squamous disease there. So all of these, apart from kind of the far left, we would warrant treatment. Actually, the nice thing is that although squamous disease looks really dramatic at times, it usually responds really nicely to treatment. It's something that we can treat relatively easily. We understand quite well, we. As I say, I think actually as a horse community now, understand much better in terms of management, how to try and prevent it. And then here we've got equine examples of some equine glandular disease. This, I say, is a little bit less understood, really, in terms of how we think about it, how we manage it, why it occurs. And we don't actually grade it, but we kind of use descriptive terms to describe what we've got going on there. So, yeah, whether it's mild, moderate, severe, focal, multifocal, or diffuse. So whether there's multiple lesions or whether they're kind of spread everywhere. Erythematous, which basically means like reddening and inflammation. Erosive is kind of what you'd expect as a typical ulcer, so it's kind of going into the tissue. Hemorrhagic is bleeding, and fibrinosuppurative is a little bit like that top middle picture where it's almost got like a yellow pussy looking membrane over the top of it. These lesions can be flat, they can be raised and bumpy, or they can be nodular like the top right picture. And we actually find that although they don't look particularly horrible, when we've got ones like that top right picture, those nodules can be really hard to get rid of and treat, and we sometimes never actually get complete resolution of them. And say they are more difficult to treat, ulcers in the glandular region. It's hard for us to know actually the relevance of them. Some horses will have those nodules and they won't have very many clinical signs. They won't be too bad. Other horses actually react really badly. Owners will describe lots of clinical signs and we treat them and the horses do really improve. So it's hard. I think there's a lot of individual variability in terms of how clinically relevant the ulcers are to the horse. But you can see, so say like that, like bottom right, where you've got erosive hemorrhagic lesions, it's not hard to think that that's going to be pretty uncomfortable for the horse, and they're going to tell you that they don't like it. So our goal when we are treating ulcers is acid suppression. So reducing the amount of acid produced by the stomach to increase the pH. So the lower the pH in the stomach, the more acidic it is. There's lots of different ways to do that. I'm sure you've heard of some of them. So the mainstay of treatment is omeprazole, which is what we call a proton pump inhibitor. It stops acid being produced in the stomach. There are a couple of ways that we can give that to horses. The kind of most common used one is an oral omeprazole, which is your Gastrogard, Peptazole, Ulcergold, Bimeprazole, Abla. They're all versions of oral omeprazole. They are pretty good for squamous lesions, but actually pretty poor at treating the glandular regions. Depending on the studies, varies between about 40 to 60% healing for glandular ulcers. So one of the reasons why it's worth scoping them, because it will help us determine what the best treatment for the ulcers is. Important to note as well with your oral omeprazole, how you feed it. So it's much, much more effective. And we always recommend actually giving it on an empty stomach, which I know sounds counterintuitive if you're treating a horse with ulcers. But we recommend kind of having horses in overnight and perhaps finishing a hay net about 3-4 a.m. And then giving them the oral omeprazole first thing in the morning. And then they need to be fed to turn on those acid pumps for the drug to then come in and turn them off. So say given on an empty stomach and fed 30 to 60 minutes later for the drug to be most effective, which is a challenge for some people for sure in terms of how they manage their horses. They might live out because that's better in terms of stress for them, which is one of the reasons why We're also using injectable omeprazole. So that is a long-acting solution that is injected into the muscle every 5 to 7 days. Much better healing rates, especially with glandular ulceration. And instead of kind of getting that acid suppression on a daily basis, where you get your acid dropping and then it creeps up through the day and it drops again, it'll actually decrease your acid, and then that acid suppression will continue for 4, 5, 6, 7 days. Which we're seeing much better results, especially with glandular ulceration. Esomeprazole is a bit of a cousin of omeprazole. It's like the stronger part of omeprazole, is given orally, and it's a bit more effective in the face of a fibre and forage diet, which is ultimately what we want to be giving these horses that have got ulcers. So is another drug that we're using more commonly, with some better results, especially with those glandular ulcers. Sucralfate is it's like a white powder. I always describe it similarly to Gaviscon in people. It coats the lining of the stomach and helps act as a bit of a mucosal bandage, helps improve the mucus production in the stomach, and protect that mucosa. So again, something we use commonly alongside omeprazole, especially when they've got glandular ulceration. Misoprostol works to kind of alter the inflammation and blood flow of the glandular mucosa. It did show a little bit, everyone got excited about it, perhaps five or so years ago. We are seeing sometimes when we use it and stop it, you get a bit of a reflex rebound of horses getting kind of worse ulcers when you stop it. But it is an oral option, especially if the omeprazole isn't working. And we're kind of looking to see what we can do. And then there are some horses where, especially where they've got those kind of raised nodular glandular lesions, where we think perhaps this is an extension of something like inflammatory bowel disease. And if we've got a lot of inflammation there, steroids are a potent anti-inflammatory. So not something that we would necessarily jump to number one straight away, but is an option if we've got ulcers that are refractory to treatment. We usually treat in, depending on the types of ulcers, 3 to 4 week blocks, rescope, see where we're at, and then extend the course if we're getting improvement, change things if we feel like we're not. Alongside all of the medications, it's really important to consider your management, nutritional management, kind of trying to reduce stress as much as possible. And that will look different for every horse. Some horses are going to be stressed if they get left out in a field and they want to come in. Other horses are going to hate to be stabled and they want to be out 24/7. Trying to have them in a good routine, kind of minimize the number of handlers we've got for them. And in terms of feeding wise, hopefully there's a lot of people who do all of this already, but high fibre, high oil if you need to get weight on them, but avoiding the sugar and starch with ad lib forage if we can. Supplements are a whole other kettle of fish. There's not a lot of evidence for supplements, but kind of individuals do report that they've had kind of good success with them. I'll often say to people that actually while they're on medication, I probably wouldn't spend the money on them because the omeprazole should be doing the job. But I think it is worthwhile having them on some sort of supplement as a maintenance kind of ongoing, because once they've had ulcers, they are at a higher risk of recurrence and getting them again. There are, so yeah, lots out there. I must admit, kind of as a vet, I like to know what's in them. So when we get kind of people saying they use this, but there's absolutely no ingredients list, vets can't tell you whether they are useful or not because we don't know what's in them. But there are plenty that are kind of NOPS tested. They will list what's there, looking for things like pectin, lecithin, that kind of create a jelly and protect the lining of the stomach. But so yeah, there's plenty out there to choose from. So what do we do? Which is a really common scenario that we get as vets actually. You've got your ex-racehorse off the track and you thought, you know what, they're not putting on weight as we'd like. They're a little bit girthy, they're a bit grumpy. So we scope them. They've got ulcers and we treat them. We know that they're getting acid suppression because they are getting their omeprazole. You're doing all the right things in terms of feeding them, trying to keep them as stress-free as possible. And you've still got ulcers that are there. Or we scope them, the ulcers have gone, but you've still got a grumpy horse that doesn't want to go forward, that's tail swishing, possibly bucking, things like that. And often it's part of the bigger picture, and we have to look at, say, yeah, the whole horse. This is just one of Lou's that I think was kind of mid us doing things with him, and kind of say it's definitely a journey that we're on with these guys. And musculoskeletal pain can definitely be a trigger and a cause for ulcers. And actually, if we don't address those underlying triggers and that underlying pain, we either get ulcers that don't resolve or keep recurring. And so we need to kind of look further. So this, I hope, is going to play. Yeah. So this is a horse, a 9-year-old ex-racer that presents with tightness through his back and not wanting to go forward under saddle. They are quite often very different on the lunge and under saddle, worse obviously with the weight of a saddle and a rider on their back. But you can see this isn't a happy horse. We've got ears back, head up, we've got tail swishing. He's not wanting to go forwards. That can be many causes, but so yeah, often, especially if on palpation they are painful through their back, we will look at that as an area of concern. So there we go. Kissing spines, which again is probably another one of the trifecta of problems that we often see in ex-racehorses. Thoroughbreds are overrepresented as horses that suffer from kissing spines, but it can affect, so yeah, any types of horses, about 40% of the general population. In terms of diagnosis, radiographs, so X-raying them, is the mainstay of diagnosis, but we do say that we don't rely on that, in that actually if horses have got no clinical signs of back pain and you X-ray them, you may well see close kissing spines, but that doesn't necessarily mean that they are clinically relevant if they've got no signs of back pain at all. So again, it's looking at the whole picture, and depending on the horse, they may well be able to clinically cope with different back conformation at different times in their lives. So if they are strong and in work and well muscled, you may find that they are able to cope much better than a horse that's had to have a period of time off because it's had another issue. It's lost a lot of core strength, and actually their back was never a problem before, but where they've become quite weak and they're struggling to carry themselves, their back is now flagging as an issue as well. So say it's definitely looking at the whole picture. Kissing spines is usually in the thoracic vertebra. So in this in these radiographs, we've got the withers to the left, and then the lumbar region to the right, and you can see we've got, this is a pretty bad case, so we've got lots of areas where they're what we call impinging, so there should be space between each of these dorsal spinous processes. There's no space at all, and we've got things that are what we call impinging or overriding, so you can see that they overlap in places. This horse as well has areas of what we would call sclerosis and cystic areas of bone. So where you can see in the spinous processes You've got kind of areas of missing bone. That would be cystic bone. And actually, when we remove these from horses' backs, you can see kind of this is like dead necrotic bone where they've had a lot of pressure. And so yeah, that you can understand why they're uncomfortable and not happy. And we also have sclerosis, which is where the bone is rubbing against each other, it's getting inflamed, and it's bright white here. So yeah, this would be a pretty severe case that we would see here.
Abs. I just want to slightly interject here. I think it's like, I think you would agree. I don't want to put words into your mouth, but when people hear the word kissing spine, is not to panic. Like, although we kind of associate it with thoroughbreds, and like you said, it might be something that some vets are quite quick to grab an x-ray machine and kind of go, well, it's an x-ray source, let's take an image of its back. And you've already said, sometimes the back might have signs of kissing spine on x-ray, but it's not necessarily prevalent to the horse at the time. Seeing an image like this, like you said, it's not a great image, but I think the main thing is not to panic. Like, I don't know if you'd agree, because everyone just
Yeah.
goes, kissing spine, the end.
Kissing spine panic. Yeah. No, definitely. I think it's so, like I was saying, they've actually we get recommended as a profession not to x-ray backs at PPE, so at vettings, because unless you have a clinical concern. Because actually, if you x-rayed, well, so if you x-rayed 10 thoroughbreds, 9 thoroughbreds would have backs where you've got some evidence of kissing spine. That said, there won't be 9 out of 10 thoroughbreds of those that aren't capable of being in work, being comfortable, showing anything. Probably over half of them will be doing a job very capably. So it's definitely, I think, especially in the milder end of the disease, it's dynamic. So I think probably the next slide says it. But you can see here, and Lou's actually we did some of this with one of Lou's horses, is that depending on the position of the horse and the position of their head carriage and their neck, you can change what those x-rays look like to a certain extent. You probably can't get rid of the bone cyst and the sclerosis of the last one, but you can see depending on how the horse is working. So in kind of that top image where they've got a lifted back, that would be something that's working really nicely over its back, is strong, has got good core strength, is nice and rounded. You can see we've got loads of space there, and that's great. That same spine, if that horse is standing a little bit like a camel, hollow through their back, head up, and say you're not moving, it all of a sudden looks a lot worse. So I do definitely think it's not a cause for panic at all. There's definitely a scale and a spectrum of things, and there are plenty of horses that can be well managed conservatively, and say I think actually, if we x-rayed every horse about, plenty of them would have kissing spines on x-ray, but would have owners or trainers would have no issues with the way they're going, the way they're working, because if they are, say, muscled and strong, they cope with it like absolutely fine. So
and it's in those 3 images, it's also the ability to have that movement through their back. Like, so they've got to be pain free. Like you're saying with the ulcers, like sometimes you might scope for ulcers and see that the ulcers reoccur because actually the horse is fundamentally in pain. But it's like they have to be pain free to be able to move from a hollow back state to a neutral back or even a lifted back. So it's like, that's your next step, isn't it? It's like if you do have kissing spine, how do we get the horse to be able to work and use themselves properly or show they're able? Is that right?
yeah, for sure. So one of the ways I think this is, yeah, I don't know. I think there was a video here, or maybe not. So there was video.
Just be like, there was a video
here. But basically, so what we do, and this goes back to kind of how clinically relevant is it. You've got that horse from the first video where they are head up, they are reluctant to go forward, they are tail swishing. We might go, okay, well, x-ray their back and it doesn't look very pretty, but how relevant is it? Because there can be a lot of reasons why a horse doesn't want to go forward. So before we jump to any conclusions, we will do what's called diagnostic analgesia. So, which is basically confirming, is it their back that's making them painful? That involves putting some local anaesthetic in those in between if we can. Sometimes you can't always get needles in between them if they are too close, but kind of through those muscles of their back, and then we will work them again. And at that point, they can't feel their back. And you will get some horses where you have a really dramatic change to that. So when they're not painful, like you say, they have the ability to then go, oh, I can lift my back and I can work properly because this doesn't hurt so much. And it's a kind of twofold, kind of confirms that, okay, we're on the right track. We know that that is an area of pain for the horse and we need to focus our attention on it. But also, if when they're not painful, they can work well, that is a bonus because it means that we can hopefully guide our treatment to getting them pain-free. They can work well and we can kind of move forward, which goes to our next one. So
the only like the good and the so with the diagnostic stuff is that sometimes what it does is if you block the back and the back is freer, sometimes it's like pulling a card from a stack of like, because I've seen it before where we've blocked the back and then the horse goes lame right hind, or then you kind of like you block the hocks and then they go lame in front, and it's like, oh, okay, there's a lot more going on here. So when you see, it's like it's the whole horse approach, isn't it? We can all get excited by a kissing spine X-ray, but it's like, how does the horse then respond? And it's also then, I think if people are considering surgery, it's a good way, isn't it, as well, to kind of like, is this surgery, if we go down this route, is this actually going to make a difference to the horse? Because there's that medication versus surgery thing, which we can go into in a bit anyway, but it's like, if you have the surgery, it doesn't mean that it'll actually help improve the horse. And I think, again, that's with the blocking, it starts guiding you in your decision making.
yeah, we would be very reluctant to do surgery on a horse the way we hadn't proven that the back is the cause. The other thing probably to mention is that so much back pain is secondary. It often, even if they have x-rays where they may have some overriding processes, often back pain is secondary to perhaps hind limb lameness or other things. So like you say, it can be a can of worms, and it's often why if they come in for a bit of a poor performance workup with us, it can be a whole day affair, because as you say, you kind of find one thing and then you pull that thread and it all unravels, and you find kind of lots of different things. But because they may well be, I say, they've got some hock pain, and because of that hock pain, they've been compensating through their back. So then they've got back pain, and actually they've been overloading on their front limbs because it's been so you can have lots of different different things. And definitely, if we want to embark on anything surgical, we will confirm before we do anything radical that it's definitely kind of like a primary area of pain for them.
Do you want to go into videos first, or do you want to talk about the two different types of treatment? What do you want to do?
You.
It's up to you. How do you think it'll best flow? Like of
should we do videos?
do videos, right? Let's see if we can do UX.
Oh, this is going to be technical and fancy. Do I need to stop sharing my screen?
You have to end your share, and then I have to start my share.
Okay.
It's a lot of sharing. Okay, you do that. That's one share, and then I have to share mine, and then pray that my end works. Da-da-da-da. Right. Did you start with conservative? Is that how we started?
Yeah. Conservatives there.
So when you're talking about conservative, we're talking about medicating back, correct?
Yeah. So conservative treatment is often steroids are the drug of choice. So they are a potent anti-inflammatory. We use them to, as Lou was saying, try and get them pain-free so they are able to work correctly. And then by working correctly, they build up the muscle in the correct way to be able to be strong enough to cope with any kissing spine that they might have. We often do that in conjunction with like physiotherapy. And lots of, everyone will say kind of term rehab. I know that's very all encompassing, but strengthening, groundwork, pole work, lots of correct working to try and get them strong. I think Lou's got some examples.
That's right. So this is Dickie. He came from the very, 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 very top of Scotland. And Dickie came with the knowledge he already had the x-rays that had kissing spine, but the vet didn't think it was relevant because when Dickie turned up, he had a split down the left front foot and the left hind. And she was saying the feet were causing the problem for him not being able to go forward and move forward. So I had to get on him and ride him and see how he went to see how he was. This was for the vet's purposes, not just because I was bored on one day and decided to give it a crack. As you can see, Dickie can't physically drop his neck and travel forward, and he really, really struggles. And he was so far behind the leg, and the only way I could really get him to go was to ride him in half seat. And the difference in him when I took the weight off his back, like we knew the x-rays were there, but it's like, are the x-rays going to be causing a problem? And you can see as soon as I go into rising trot, the head and the neck comes back up. So yeah, as soon as there's any weight on his back in terms of a rider like there, he's already bracing and waiting for it. We already knew that the back was relevant before we'd even blocked and medicated. The thing with Dickie is he is that horse that we pulled the thread and everything did fall apart. So we blocked and back. He then went lame right hind. So then we blocked and medicated his hocks. And then he went lame left fore. And the left fore was the one with the split, but it wasn't the split in his foot that was the problem. It was his coffin joints. So he got his left foot medicated as well. And then we had one sound horse. The reason Dickie didn't have the surgery is because his back, out of all the processes that he's got, 9 of them had like different forms of kissing spine. So he wasn't a surgical candidate. And where he was at home, his owner felt confident and competent to be able to look after him. This day, it was just raining. Every time I rode this horse, it rained, bless him. But he did come from John O'Groat, so he was used to the rain. But you can see here, like you can even see his clip patches on his SI. This is only like the first ride post injections and him having a bit of time off. But he could already go forward. He could already drop his neck. I didn't have to go in half seat. This isn't, all he's done is had a week off post injections, long reining for a week, and then I've got on him, and he's already a markedly happier horse and able to ride forward, drop his neck, and go. So that he was not a surgical candidate. But we medicated him, and then it was a case of mixing up long reining with riding. We also changed his diet, and then as soon as he was more comfortable in his body, he then wasn't overloading the left side, and his feet the cracks started to disappear because he wasn't throwing himself onto his left side to compensate for everything else. But this horse was a whole team approach, so it was vets, nutritionist, farrier, saddler. It was everybody, which is why when you medicate, it can be quite overwhelming because there are a lot of things and people involved. And you have to be able to watch a horse and understand what's going on. And the problem is when we watch horses, we overwatch them as well. And if they sneeze in the wrong direction, we think something's going wrong. So it does require being able to have trusted people around you and knowing how to get through things. So that was Dickie on surgery. Don't know if there's anything you want to add, Abs, on that one.
Yeah, no, I think, it's a good example that, yeah, surgery is not going to be the answer for every horse. And I think I think it's very individual to the horse, the owner, the circumstances, what the horse wants to do, how the horse is coping, what the horse's x-rays are, and often what their response to medication is, because we'll have some horses that, a bit like you say, Dickie's done really well. You medicate them, they automatically go, oh yeah, I feel so much better. He probably had a good degree he had a bit of primary back pain, but also some secondary back pain if he's got hocks and SI problems as well. And so by kind of looking at the whole horse and kind of getting him comfortable all round, we can manage him really nicely. There might be some horses that you medicate their back and it might only work for a couple of months, and you're not going to want to be medicating their back every 5 minutes. And so they might be, but you've proved it's their back through blocking their back and knowing that that's the problem. They might be more horses that you go, okay, yes, like actually perhaps surgery for them is the right answer. I think one So yeah, as vets, we're not supposed to kind of lean too much towards one insurance company or another, but I think kind of looking at lifetime policies, e.g. Agria, that can help, because I think one of perhaps the pressures that owners feel is deciding to do a surgery, and you feel like you have to decide to do surgery within that year where you've got your insurance policy for their back, which can be really tough, because actually you might want to try medicating their back first, doing the physio, getting them stronger, seeing how they cope with that. And then if that doesn't work, going to surgery, which is a very sensible plan. That said, some people actually feel that with the time pressure that kind of a year's insurance policy gives you, that they want to get, the surgery, which is, 5,000-6,000 pounds, depending on where you are. That is something that we insure the horses for a reason. And you want to get under there, that we end up doing, I say, yeah, probably some owners feel like they have to jump to it quicker because of doing it. But yeah, benefits of a lifetime policy, actually that time pressure would be taken away a little bit, and you can decide what's right for you, your horse, and the situation.
So then we moved on to surgery horses. If I had audio, if I had kept the audio on this video, it literally has me doing half a lap and going, oh, for God's sake. And then I pull up. So this horse, I didn't even ride this horse. I didn't even get on this horse. We didn't know what was wrong with him in theory, but this horse came in to see if he could possibly do schooling. This horse, as you can see, is actually lame when he's on the right rein. And the weird thing is that he's kind of not lame through his legs, but he's almost bridle lame sometimes. So it's a bit of he goes a bit on and off lame every now and again through the turns. But he was fine without a saddle on. So he only did this when a saddle went on his back. And I was like, game over. Right, we need an x-ray, because there was no point. And so his owner was like, I just want to know if I could possibly do hacking and a bit of pole work, and the odd schooling session. And I just thought, this horse can't even move freely. He was worse on the right rein than the left rein. And so I just pulled up after this. I didn't even bother sitting on him. And these were his x-rays. So this is the front part of him, so the wither, and then moving back, you've then got basically Beautiful. Everything's just kind of fallen into his wither. It's gone into his wither, which would also suggest why the horse then kind of goes nodding in front. And his front feet, he was chronic for losing shoes all the time. And he did have the surgery. And the main reason he had the surgery was because his owner was like, I am neurotic about this horse and I love this horse, but I watch this horse like a hawk, and I don't have the confidence to be able to know, is he struggling that day or not? I don't have an arena. I haven't long reined before. I don't feel confident in my own abilities. And so therefore I have the insurance and I would like the surgery. And it took a lot for her to be that honest with us and herself, and I really do praise and admire her for that. And so this horse had the surgery because of lack of facilities at the time, lack of knowledge and lack of confidence. And then therefore we knew that he needed some help, and managing him through injections wasn't going to give this owner any sleep at night. And he was a surgical candidate.
But side note, I'm not sure this horse ever gives his owner any sleep at night.
This horse is a walking calamity. This horse likes to just, make his owner's life great.
I think he's probably filled about 4 loyalty cards at the vet.
It really has. So he was a surgical candidate. He could have been managed through medication, but again, it was really brave of his owner to be like, I would feel happier and more confident to just know that the problem's been taken away. And we were like, okay, cool. And so that was him. And he did, as a result of the surgery, he also had his hocks medicated. And he did also have his front feet medicated, and he had pads on his front feet just for the first, I think it was 8 to 9 months, just as a precautionary type thing. But again, it was him. The hardest bit for this horse was actually then learning mentally that it no longer hurt, because he felt for quite a while that he couldn't do it. And we knew that the bone was gone. So it was like, well, you can. And that was quite difficult for him. But fair play to his owner. She's really persevered, and it's a really lovely thing to see them go around now and how strong and how happy he looks when he's not trying to muller himself in between from various other extra activities. Um, Abs, I don't know if you want to go back to your
Yeah.
sharing on that. Sorry guys, a lot of intermittent sharing. We couldn't get all the videos to come together and play. Um, so yeah, there we go. So I don't know if it's
Yeah, fab. So yeah, I think we've probably spoken. Can't emphasize enough actually whether you go conservative or surgical, how important physios are. They, I think, with surgery, so much of the success is actually on what we call either the prehab, which is actually starting to do physio and rehab with them prior to surgery, which is where medication before surgery can help. And the physio post-op. It makes such a difference. We often encourage people to get their physios involved from 2-3 weeks post-op, and they are the guiding lights actually, kind of after surgery, and will really kind of, so yeah, make or break how they go. So yeah, a good physio is invaluable. And we work quite closely with a couple locally to us. In terms of surgery, there's a couple of different options. There's what people sometimes call the ligament snip, which is I say posh name is interspinous ligament desmotomy, which cuts the ligaments between the processes. We actually think that's a little bit of denerving. So where we cut the ligament, we also cut the nerves to the muscles around the back, and that temporarily damages the nerves there, so they're not too painful. You can see from kind of some of the x-rays that we've shown you that where they are so close and you've got bits of bone cysts and sclerosis where the ligament snip is often just not enough if you're going to go down that surgical route. And sometimes we'll do a full resection, which is where we cut out, there we go, where we cut out the spinous processes. And you can see here, this is a horse post-op, mid-op maybe, where they've had 2 spinous processes removed. And you see we take away the bone, so they physically can't rub against each other anymore. And we tend to take away every other, so therefore kind of creating the space. We, in terms of kind of how well they do, up to about 3 processes being removed, they tend to return to kind of their previous level of athletic function or above. The more processes you have removed, the less likely they are to kind of return to kind of the level of work that they were in. So that is something to take into account as well, when deciding if it's right. Actually, if that horse needed 5 or 6 processes removing, is that the right option for the horse? But definitely something to kind of talk through with your own individual vets, because it will vary for every single horse and every single owner.
I don't know, Abs, whether you want like the surgery option is it's intensive. It is like labor intensive post-op. Like it really is like dedication 101. Like it's hard going. It's not that it's not possible. I'm not trying to put anybody off, but it is like within the first week, for example, you're cold packing these horses' backs 2-3 times a day. So you're standing there with an ice pack on these horses' backs, trying to kind of reduce that inflammation, promote the healing. You're then kind of going through the stages of 8 weeks on box rest, 4 weeks completely in the box, then start being able to hand walk these horses, then putting them in long reins, restricted turnouts so they're in a pen so they don't run around because that surgical site, you've gone through layers and layers of muscle. Like it's it's a hard thing to do, the rehab. It really is. It's really, really, really intensive. And like your physios are getting hands on sooner rather than later. Um, it's a lot because it's like at least 3 to 4 months until the horses are back under saddle, isn't it? Kind of with a saddle on their back.
Yeah,
Like,
it definitely varies horse to horse. But it's say, yeah, they'll have strict box rest for 2 weeks while they've got staples in, and then the staples get removed at 2 weeks. Say, as Lou says, within those 2 week periods, we really recommend cold packing for that anti-inflammatory and aiding of healing. We will also use like class 4 laser, which helps promote healing and prevent scar tissue as well in the kind of early days post-op. And then, so yeah, then it's some hand grazing, but 4 weeks in the box, and then hand walking from the box, and slowly kind of increase controlled exercise, which having not for kissing spines, but having done it with myself, it's for myself, it's very easy as a vet to say, can you just hand walk this horse for 4 weeks? And then when you've got to do it as an owner, it's tough, especially if you've got something that's you're doing it from the box and it's explosive and difficult. We do, yeah, it's usually about 3 months before we have a saddle back on. Again, that varies horse to horse. And a bit like the horse Lou was showing you videos about, there is definitely an element of kind of pain memory and trying to work through that as well. So we might have some horses that do take longer than that because actually every day of their life pre-surgery it hurts. So it takes a long time to help them realize that it doesn't hurt anymore. So it is slow and steady, and it's not something that's kind of a one shot and done either. I think these horses, I know people kind of think, oh, giving horses holidays is a great idea, but sometimes, especially with these horses that have got back pain, holidays can be the worst thing in the world. It happens to me and my mare all the time. She'll go lame in one place and then she has some time off and then she falls apart everywhere else. Because actually having them in work, making sure that you're keeping them strong, helps them cope. And they are much better for it than actually when they lose a lot of that muscle. So even though we say we do the surgery and you've done it, it's kind of like a lifelong commitment to keeping them strong and well. Not that that should be scary. I think hopefully we all do that for our horses anyway. But I think yeah, it's not for the faint-hearted. And actually, once you've experienced it once, you feel a lot more confident to do it again. But it's dedication, and I think kind of the commitment and the dedication of the owners is probably more important than the surgeon who's taking the processes out.
It's also difficult to know which time of year to do it because I get quite a few horses that come in winter. I'm talking like November, December, January, winter, with horses that have had kissing spine surgery because quite sensibly, no one wants to ride in winter. But then we're trying to do hand walking from the box in gale force winds and snow and torrential rain, and then trying to get them out in a turnout pen without boggy ground. Like, but then everyone wants to ride in the summer, but then you don't want to do it in the spring. Like, it's really difficult to know if we're going to do this, when is the best time to do it. So yeah, it kind of swings and roundabouts. But yeah, I get quite a few horses come in the winter because understandably, no one wants to be walking for 45 minutes behind a set of long reins with a horse that's on minimal turnout. No one wants to do that. So it comes like we get them, which is fine.
Hands
But yeah,
up, I'm guilty. I sent my horse to Lou. I asked her to do it instead. So yeah,
it's like
yeah.
get one.
So
Yeah.
no shame. Yeah.
Difficult. Abs, is there a certain age where you wouldn't do the surgery on a horse with kissing spine, or is there a certain age you're like, no, that horse is too young, or there's like, are there any ever any age limits?
Um, Not necessarily age, I don't think. We always kind of say age is not a disease. I think you've got to take the whole picture into account. So actually, if you had a 18, 19-year-old horse that also was very arthritic through its hocks, and had multiple other issues, was struggling to keep weight on, would it be the right thing to put that horse through surgery? Probably not. Whereas actually, if you had a 20-year-old that was still going out competing, doing novice elementary dressage and was doing well, then yes, we wouldn't say no to doing that surgery. So I don't think necessarily age itself is an issue. It would be more kind of the condition and like other comorbidities that horse has. And I think young wise, I suppose yeah, we probably wouldn't do it on something that isn't fully mature. So you're not going to be doing surgery on a 2-year-old. But once they are 4, 5, 6, yeah, we would.
Thanks. That's it.
I think I'm just looking at the questions in terms of I think I say lumbar. Someone's asked about kissing spine in the lumbar region. It can be harder to diagnose just because getting x-rays through that region is harder. Sometimes scanning helps, and it can be a region where surgery is sometimes less successful actually, and harder because the muscle mass to get to those areas is more. I suppose one of the benefits there is that we often don't have the weight of the saddle and a rider on that part of the horse. So the lumbar region would be, say, behind where the saddle is. I think, yes, sometimes we will medicate that area, but it's not an area that we often kind of the beginning of the lumbar region, we might take a spinous process out of, but certainly kind of towards the back of the lumbar region, we would rarely do surgery on that site. I think that's most of them. Perfect.
Oh, and Dickie, like someone did ask, did Dickie stay sound? Yes, he has stayed sound. He's still up in Scotland. I taught him last week via Zoom. He's all happy and grand, and she keeps up his medications. He ended up having them every 6 months for the first 18 months, and then they now prolong to every 9 to 10 months. And he doesn't have the front feet medicated anymore, so he's now just back and hocks. And when he needs it, he gets the SI, as in when he's sore, but he doesn't have as much as often because again he's stronger and happier. So Dickie is fine. Frog is fine. Frog lives on. Help Toaster reach their yearly targets. Frog is still going.
Yeah, Frog is famous. His poor owner doesn't even have to like say her name. We recognize her voice on the phone. But we love him. We love him.
We love Frog. Frog is a charmer. He is a character. And how his owner is not grey and rocking in a corner somewhere. He is lucky he found his owner.
He's very lucky. Yeah. So kind of going on to probably, yeah, to say the third of the trifecta of, I say the ex-racehorse, but many a horse is, and something that we see really commonly is foot balance in horses. So this is something that I think, say, affects a lot of horses, and perhaps can say prevalence wise thoroughbreds might be more kind of like long toe, low heeled compared to warm bloods that sometimes have problems for being the other way. So it can, say, affect everybody. So 90% of forelimb lamenesses will be originated from the foot. You can see, I say that's a very, I say very an extreme example of a horse there that's got what we'd kind of term as like long sloping pasterns. It's got low heels with very little support there, and long toes. And hopefully, we wouldn't be surprised if this is. It is lame. It looks like it's had a block somewhere, so I think it probably is that we've got a photo of it. And some of this is conformation. So it's not a case of we're necessarily going to be able to change it because it is how the horse is built. And if you actually fight too hard against their conformation, you can make them more sore in other ways. But knowing what their conformation is and how you can work with your farrier to best support that, we can definitely kind of try and make them as comfortable as possible. So looking, we often look at them standing still to start with, standing square, and then when you ask a horse to stand square is absolutely when it can't do it. And we look at what's called the hoof pastern axis. So we're in an ideal world, we want that to be a straight line, from drawing a straight line from their along their pastern and through their hoof, and when you see it on x-rays, through their pedal bones, through P1, P2, P3. We have two different problems, and say they both come with an issue. So that classic, what people would term thoroughbred feet, is what is often called broken back. So we always remember it's the arrow points backwards. So they are, say, sloping backwards. You can have then the other issue when they're broken forwards, if they've got a club foot. If they've had injuries and things like that, the arrow points forward. Neither are good. We want it to ideally be a straight line. Which, so yeah, that's pretty, although they've got some what we call dorsopalmar imbalance there, you can see that's a straight line. So dorsopalmar, we use dorsal for the term of the front of the foot, palmar for the term of the back of the foot. That all should be parallel in an ideal world. And then medial lateral, we've got medial is the inside of the foot and lateral is the outside of the foot. And again, they should be level in an ideal world. There can be lots of reasons why they're not. Again, it can be conformation, it can be injury, it can be shoeing. Sometimes they will weight bear differently if they've had an injury higher up and they've been offloading that limb, or as Lou was saying earlier, actually if they are painful in different areas of their body, so they are compensating or using their bodies differently, that can affect how their feet grow and how they're loading their limbs, so therefore kind of hoof growth as well. So how we find out if it is foot pain, we again do that diagnostic analgesia. So we focus on the nerves that supply the foot. So the first block that the vet will usually do is called a palmar digital nerve block, where that white dot is there. That we put some local anaesthetic around the nerves. That nerve supplies the heel of the foot and about 2/3 of the foot. So that will block out a lot of foot pain, but not completely all of the foot. If we don't get anything from that, we will move up a little bit. So we'll do what's called an abaxial sesamoid nerve block. That's where if anyone's feeling digital pulses for laminitis and things, that's that vein artery nerve bundle at the side of the fetlock, and putting local anaesthetic there will mean your horse can't feel kind of from below their fetlock downwards, and we will trot them up in a straight line, on a soft lunge and on a hard lunge, get a baseline view of them, then do those nerve blocks, and then we'll repeat that and trot them up again and see have we got an improvement. Anything over a 50% improvement we call positive. Often with feet, the most obvious place we see that lameness is on the hard circle, and it will usually be the inside foot. So left forelimb on the left rein, right forelimb on the right rein. It's the bit that everybody hates at a vetting when we're trotting them on a hard circle. The other thing that we can do and see is the desensitizing their coffin joint. So that is specific to the joint itself. It does also affect the navicular bursa, the navicular bone. And if they have side bone, I think this video is us doing a coffin joint, she says. Yeah, there we go. So you can see the needle's inserted, we get some joint fluid dripping out. And then we pop the local anaesthetic directly into the joint. So that can, sometimes they will block to a coffin joint with foot balance issues. Sometimes they won't. The coffin joint can also have like synovitis, so a strain. It can be arthritic changes. There can be lots of reasons why they would block to a coffin joint. And this just shows you, so here we've put some contrast into the coffin joint. So the coffin joint is that kind of what's glowing bright white there, and you can see it does travel around the navicular bone, which is that small kind of cube bone at the back of the foot as well. So yeah, this shows, hopefully this is quite obvious. I think I picked some obvious examples of us trotting the horse on the hard circle. So this is before. Excuse the audio, I think it's obviously going how lame it is. So you can see we've got a really obvious head nod there.
Ouch, 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 ouch.
Holly going ouch about how much it hurts. So we would definitely say that is lame, therefore. And then post blocking. She's had a coffin joint block. We have also blocked a hock. You can probably tell by the pink bandages on her back legs.
It's, I think, much easier to learn in practice than it is on paper.
Yeah. But you can see, actually, we've not got that head nod anymore. She's much happier, much more comfortable. And that's what we're looking for when we're doing the nerve blocks, is see a good improvement from them. So when we have done our diagnostic analgesia, we know where it hurts. We will often x-ray their feet and double check, say what's going on, looking at the balance. So two things that we look for. We look for that hoof pastern axis. So we want a straight line between their long pastern bone, their short pastern bone, and their pedal bone. And if in an ideal world, their middle of their coffin joint, if you drew a straight line down from that, you should have half of the shoe in front of it and half of the shoe behind it, showing kind of we've got some good support for the foot there. And then we're also looking at what we call a medial lateral balance. So we want it to be even when we're looking kind of face on. No, I'm just going to go and turn some of that lights on because I think no one can see me because it's getting dark. 2 seconds. There we go. It's a bit easier. It's just sitting in the dark and realizing that no one can see my face. So these are some examples of some not so good feet and things that we can definitely work with farriers to improve. So you can see here, we've got what we call a negative palmar angle. So the bottom of the pedal bone should be parallel to the bottom of the foot or the shoe. Here you can see that actually it's not even flat, actually, it's sloping downwards. So that would be what we call a negative palmar angle. And if we look at the center of the coffin joint, we've got about a third of the shoe at the back and more at the front. So actually we can do quite a lot to improve this horse's angles. And you can see this is kind of, yeah, say before and after. You can see the difference of that pedal bone palmar angle being flat to negative. It's not amazing afterwards, but we've got a much better hoof pastern axis. And instead of kind of half of the shoe, 2/3 of the shoe being in front and a third of the shoe being behind with no palmar support for the heels, actually with some, we've got much better there. And you can see on that 50/50 x-ray that the horse has got some wedges in. So we're just trying to lift those heels and improve that palmar angle there. This is where I cringe because these are my horse's x-rays. And I'm like, oh, that looks so horrible. Actually, you can see here that what we call that hoof pastern axis, we haven't got a straight line at all. We're a little bit broken back. You would say that actually the farrier's trying to do a good job there because we've got half the shoe in front at the coffin joint, we've got half and half. So they're trying to give that horse good support, but she's a little bit broken back. You can see on the when we're looking front to back on the horse, like so lateral is where it says lat and medial is the inside. You can see actually she's got lateral flare and then just no medial hoof wall at all. That's actually due to injury, so she doesn't grow much medial hoof wall, and sometimes the farrier has to build it up with cast material or resin. So it's not really the farrier's fault, it's how the horse grows or doesn't grow hoof. But you can see how different they should be a mirror image of each other, and you can see how different the two lateral and medial sides are. This is again quite an extreme x-ray. You can see this horse here has got no sole at all, really long toes, and again we're completely lacking that kind of support behind for the heels, and we've got a negative palmar angle, so that pedal bone is almost dropping down rather than being parallel, or ideally a little bit like that from the shoe. Medial lateral, kind of either side, it's not too bad. But yeah, definitely not a very happy foot there.
What would you say if you go back one with that? To me, that's a hind foot. Is that a hind foot? Please tell me that's a hind foot. If that's
No,
a front foot,
that's a front foot.
I'm worried. Okay, let's just say that's a hind foot. The knock-on effects of having, because I think in thoroughbreds I could be generalized, but I think you see this more in hind feet and thoroughbreds.
Yeah, we see negative palmar angles. We see all round, but we will see it in hind feet, not just in thoroughbreds, in everybody. The thing that we often worry about and see in combination is suspensory disease, because we're putting extra strain on their suspensory. So if you can imagine, you've got your suspensory apparatus at the back of the foot. If that is being pulled more and more down, you're putting more strain down the back of the leg. So actually, especially in horses with suspensory disease, we will often x-ray their back feet. And a lot of them have negative palmar angles, and we end up putting wedges in there. So instead of that pedal bone being like this, we raise the pedal bone up, and you then take away the strain on the suspensory at the back of the leg. So it can definitely be in combination with other things. Yeah, but no, I think this is a front foot, sadly. This is, I say, post. So you can see here, that's exactly what the farrier has done. You can see we've got those 3D pads in there. So instead of that pedal bone angle being falling down, we're actually now sloping it up. So we're doing kind of, so yeah, multiple things. He's got more heel support. We're changing that hoof pastern axis to improve it, and we're going to be taking away a lot of the strain on the flexor apparatus at the back of the leg as well. This bit, a shameless plug. I forgot this bit was here. So because of all of this, actually Lou came to us and went, thoroughbreds have all of these problems. How can we look at this and try and just do something to help them? Because I think often this can be a really, really long road. We might scope them first, treat those, then they come back, then we have a look at them from a musculoskeletal point of view, and we might find that they've got back problems, a little bit like Lou was saying from ones earlier. They have back problems, then you find that they also need their hocks and SIs injecting, and then you might find out that they've got foot balance problems in front, and that can take years without kind of exaggerating. It often does. And we actually thought, can we do this better for kind of the welfare of our horses, and trying to get them comfortable and looking at the horses as a whole picture, rather than kind of just focusing on one area or another. So we have now, I think we've had a fair few through. It's been really nice as kind of for a bit of a discounted cost, scoping them, and then whilst they're asleep, taking some back and foot x-rays as well. Just, and not necessarily having to do anything about those, but just so you're armed with all of the information. And you know what's there. We'll share the foot balance x-rays with your farriers. We're more than happy to chat to farriers and kind of come up with best plans for helping them be most comfortable through their feet. And so yeah, ultimately trying to get them comfortable and stopping it taking kind of months and months and years, and doing that, so yeah, in a way that's best for them. So yeah, we've got also with the thoroughbred package, it's Annabelle Galt, physio, and Denji are doing feed vouchers and feed consultations as well. So again, keeping that kind of home team feel, and including everybody, because it is definitely a team effort to keep these guys happy and healthy. I'm going to say everyone's going to say, oh, ex-racers, but I'm a sucker. I've had plenty, and I don't think I'll have anything else. So they give us their fair share of problems, but I think they're worth it. So yeah.
And I just want to make sure, like, so the one question that we haven't looked at as well is from someone, how would you suggest to reduce stress to prevent ulcers when welcoming a new horse to the yard? They have an older horse that they are arriving next week. Sorry, the horse will be older. The horse is arriving next week. Any management tips? I would I would say very quickly is like um ask the person that you're getting the horse off what routine the horse is in at the minute. If they're stable at night, if they go to the field, if they're out overnight, if they're out 24/7, do they go out with friends? Do they not? That would be your main thing of trying to keep their routine as similar as possible. I always say World Horse Welfare, the three Fs, which is, friends, forage, and freedom. So it's not throwing them out forever if that's not what they're used to, but making sure they have those three things. So they have food. Don't panic if they don't want to eat as much in the beginning stages because it might be new to them and they're worried and panicked. But I think if you can reduce stress, you can reduce ulcers. But yeah, the main thing is trying to provide that same life in a slightly different scenario, which I know sounds a bit weird, but if you try and keep to what they are happiest with and currently doing and currently feeding, and if the person you're picking them up allows you to take a scoop or two of their feed, so you can slowly mix it over, great. And the same with their forage, great. Try and keep the same stuff. And anyone that wants the best for that horse, they will give you a hay net of hay. They will give you a couple of scoops of feed, hopefully, if they're a good human. I don't know, Abs, anything on that?
Yeah, no, I think that's great advice, and we always say like trying to change any feeding over slowly. So trying to do it over the kind of the space of a week, if you are wanted to change their diet, and things like that. I think depending on, say, if they've had ulcers and things in the past, if we know horses have ulcers, we might use preventative doses of omeprazole. So we'll use like a quarter of a tube of omeprazole over kind of the couple of days of when they're moving, just to try and prophylactically prevent any ulceration. If they haven't had ulcers before, that's possibly a bit overkill, but even some of the like probiotic supplements, you can get like gut balancers and things, are all going to help try and maintain a like healthy, happy hind gut environment, whilst things are going through change. Ultimately, even if you try and keep as much the same as you can, your grazing is going to be different from where he was previously, and so something like some probiotics could just help, help him through that change.
NAF do a really good syringe called Instabiotics or something like that, which it's got a front, pink package, which I really can't help with the exact words of what it's called. I know it's pink package, but yeah, I really rate those. They're really good because I have some horses that have had colic surgery and their guts don't hang up very well if they're traveling or they're slightly stressed, and that stuff seems to be really, really good, along with like the Protexin. Is it Quick Fix as well?
Yeah.
And they've also got one which is something buffer. What's it called? Something
Oh,
buffer. It's like gut sponge, but for like in powder form. It's really
oh, I
good.
don't know one that's called buffer, but there's plenty. Saccharomyces cerevisiae is the active ingredient that you're looking for. That's in all of the probiotic ones. That's the bit that's included.
Um,
Saccharomyces.
and I think we've got like one of the best questions to possibly finish on.
I like this. Again.
Are there any misconceptions regarding thoroughbreds from a vet's perspective?
That's a good question. I think I think it probably depends on the vet. I think perhaps everyone thinks they are silly, fire-breathing dragon like wappy things, and some of them will be for sure. Say mine included. But actually, so many of them are chill. I think they get a really good start in life in a lot of ways, in that they are exposed to so much. They're very good at traveling, they're very good at going to different places. They have a lot of vet intervention from an early age. So, the vast majority of them are really well behaved for things like needles and scopes and things that we need to do because they're very used to it. I think sometimes they can, yeah, probably possibly come off a box looking like they're about 20 hands high, and head in the air, and that you're thinking, oh my gosh, but actually, they're not bad. And I think possibly, again, this really, really depends on the horse, but I think knowing when to pick your battles, I think, in that, I know certainly kind of speaking from experience of mine and other thoroughbreds is that actually once they get wound up and lose their heads a little bit, there's no point arguing with them. You need to just let them come down, chill out, and not pressurize them, whether that's then sedating them to do what you need to do, or just giving them a little bit of time to come down. But yeah, I think perhaps people think that they're going to be a lot worse from a vet's point of view than they are. They're often very well behaved because they've done so much.
The only time I think vets get it is when they reach for the hoof testers and they put a pair of hoof testers on a thoroughbred and go, "Oh, they're reactive," and you're like, "Uh-huh."
Yeah.
That's probably about my only thing. I'm like, yeah, no, no shock. Or shall we just trot it up on this stony bit? How about no? How about let's not? Honestly, Abs, it's been brilliant. Thank you so much, Ali. I don't know if Ali, I know always listens, but I don't know what stage she's at of cleaning child.
I'm here. Child is asleep.
But no, honestly, thank you so much. I said Ali, we forgot to put in the Agria QR code. So is it all right to send it to
I
people
will
on the?
send it out to everybody tomorrow. Yeah, no worries. So yeah, this will go out to everybody tomorrow anyway. So yeah, I'll include the Agria QR code for sure.
Thank you. But yeah,
Yeah.
that's it. The end. Thank you.
Thank you so
Thanks.
much, guys. That was really, really good. It's absolutely fascinating, and I'm sure everybody got a lot out of it. I certainly did.
Always candy and good. And next month is about cantering. We were confirming this before we started this.
And I will send out an invitation again tomorrow with the link. So there'll be the invitation to register for the next one as well.
Fabulous.
Fab.
Amazing.
I think I probably need to come if it's on cantering.
Yeah, I might even use some videos of Annie like cantering sideways down the long side on the right rein and be like, this is
Straightness. What's straightness? That doesn't exist.
very common.